Hi, everyone, and welcome to another episode on a podcast on medicine, health, and society. Today's episode is titled Lost in Translation. Okay, so for today's episode, we'll be using a medical sociological lens to talk about language barriers in healthcare and how they can impact patient-centered care as well as overall health outcomes in both individuals and communities. This topic is really important to me personally because since a young age, probably 12 or 13, I've been the one to translate and advocate for my grandparents who primarily speak Spanish in healthcare settings. Now that I'm older and I work in healthcare settings, I notice the same trend of that difficulty of communication between patients who don't speak English and providers, which then translates to a lack of patient-centered care and sometimes even negative health outcomes. Considering I only see a pretty small fraction of limited English proficient, which is LEP patients, I can only imagine how many other individuals, families, and even communities struggle with this same issue. According to the Kaiser Family Foundation, about half of immigrant adults in the U.S. report LEP, which accounts for millions of people who may not be receiving the highest quality healthcare that's available to them. Therefore, we're going to be talking about various sociological theories, such as the fundamental determinants of health, medicalization, health lifestyles theory, and social epidemiology, and see how they can be applied to this specific issue impacting millions of people. So to start, we're going to be going over the fundamental determinants of health theory, which follows four main propositions, which include access to resources to avoid and minimize disease, influence on multiple diseases, affects disease through multiple pathways of risk, and reproduction over time. This theory mainly focuses on how agency versus structure and how individual choice as well as socially constructed constraints play a role in the spread of disease and overall health outcomes. This theory also takes social conditions into account, which can include ethnicity, gender, social class, and other things. In this specific case, ethnicity is the social condition because it's so many times tied to limited English proficiency, again, LEP. So let's go ahead and dive into the four propositions of this theory. So first up, we have access to resources to avoid and minimize disease. Due to language barriers during primary, secondary, and tertiary levels of care, patients with language barriers may not really have access to the same resources as their counterparts who do speak English to avoid and minimize disease. So, for example, resources and health information may not be given to these patients in their first language. So many times in health education resources, such as flyers, packets, posters, and other formats, they're not printed in various languages and typically only English. So therefore, if they are given these resources in English, they may struggle to understand the content without an interpreter. The next proposition is influence of multiple diseases. The main example I'll be using for this proposition is how language barriers can impact both chronic and acute illnesses. So, care and management of chronic illness is lifelong, as we know, and it can span across years and countless doctor's visits over somebody's life. Chronic illness is very dependent on patients being educated on their condition and knowledgeable of the steps that they have to take to make sure their condition is being managed appropriately. This can be a number of things, sometimes taking their medications correctly, scheduling follow-up appointments, knowing baseline signs and symptoms of their illness, and so much more. Patients with LEP are at a higher risk of not being provided with the resources to do these things, and oftentimes may not even fully understand their responsibilities within their health management just because it has not been communicated to them properly. Therefore, they're also at a higher risk of their chronic illness to cause a decline in their health due to the communication barrier between them and their providers. Even if a patient with LEP doesn't have a chronic disease, if they aren't receiving proper health education in their first language, this can be healthy lifestyle habits or preventative treatment, they're at a high risk of developing a chronic illness over time. On the other hand, acute medical care can also be impacted. So, for example, inpatient hospital settings are considered to be acute, such as the Chandler Hospital that we have here at UK's campus. So given the shortage of in-person medical interpreters, many large hospitals like our own at UK have begun to use remote telephone interpreters during patient interactions. But actually, according to a study in the Health Promotion Journal of Australia, telephone interpreters come with a number of challenges, such as long wait times for an available interpreter, poor internet connection in hospital areas, and working with populations who are hard of hearing. Additionally, using telephone restricts the ability to use nonverbal communication by both the patient and the interpreter. In combination, these challenges can cause a lot of miscommunication about important medical information, delays in care, and more. The last proposition is reproduction over time. As I'll mention later on in the episode, social epidemiology shows us that certain patterns of disease are more prevalent in communities that experience LEP. Given that negative health outcomes often coincide with medical debt, low socioeconomic status, lack of access to healthcare, and other factors, it can be really easy for communities to fall into a cycle that is systemically very, very hard to break. And once communities do fall into this cycle, it can span over generations of poor health and negative health outcomes. Let's go ahead and jump into our next theory. Alright, so the next theory we're going to touch on is medicalization. According to the content of this course, medicalization is the process by which non-medical human conditions become defined and treated as medical conditions. Although English proficiency is not considered a medical condition, it has been considered a non-traditional comorbidity in various studies. For those not familiar, according to the Cleveland Clinic, a comorbidity can be defined as a distinct medical diagnosis that a patient has in addition to their primary diagnosis. For example, a study published in the Journal of the American Medical Association explored the relationship between LEP and inpatient sepsis mortality rates. This study actually found there was a significantly higher mortality rates in patients with LEP compared to their English proficient counterparts, which justifies the label of a non-traditional comorbidity. Therefore, LEP has not been medicalized under the sociological definition of medicalization, but we can see how the human condition of language directly impacts morbidity and mortality and overall health outcomes. The next theory we're going to talk about is the health lifestyles theory. Okay, so what is the health lifestyles theory? According to the content of this course, it can be defined as a theory that expects group norms, such as cultural norms, and their understanding of healthy behaviors to vary from group to group. It also focuses on the idea of agency versus structure, and oftentimes individuals who have LEP come from ethnically and culturally diverse populations. As we know, there's a disconnect about what can be considered healthy versus what's not healthy, as well as a baseline medical knowledge and beliefs across different cultures. So this greatly impacts patient and community-centered care because many providers are not culturally competent outside of their own culture and don't make an effort to meet these communities where they're at in terms of their health and their health beliefs. So this disconnect can oftentimes cause poor health outcomes, poor patient and provider relationships, and just an overall distrust in the medical system. Next, we'll be talking about social epidemiology. So this last theory we'll talk about is social epidemiology, which is the study of social conditions and how they determine and influence health outcomes of different populations. It also takes into account time and place in order to better contextualize the statistical distributions of health across populations. In this case, the social condition is ethnicity, which also encompasses LEP since the two are so closely related. There's various data sets and studies that have found an association between negative health outcomes and ethnicity. For example, in 2023, according to the Centers for Disease Control and Prevention, based on their epidemiological data, ethnic minority groups in the U.S. experience overall higher rates of death and disease across lots of different health conditions, such as diabetes, hypertension, and more. This is a perfect example of social epidemiology, as it ties the spread of disease to a social condition such as ethnicity. That's all I have for today's episode. Hopefully by now you all have a better understanding of limited English proficiency in healthcare from a sociological lens. Overall, if you get anything from this episode, let it be that I encourage everyone to be a strong advocate for quality healthcare for all, despite socioeconomic status, ethnicity, English proficiency, and any other factors. Thank you for listening to today's episode.